Good morning, everyone. Thank you again for coming. Today we have Dr. Evan Noch here with us. He is a neurologist at Weill Cornell, and he's also working in a lab. Dr. Noch, go ahead and get started whenever you're ready.
Okay, great. Looks like I can't share my screen though. Are you able
Oh,
to enable that function?
yeah. Malika, can you make him host?
Yeah, I'll make some calls right now.
Okay, great.
Yeah.
All right, we should be good to go then. So hi everyone. My name is Evan Noch. I'm assistant professor at Weill Cornell, as Mia mentioned, and I also serve as a neurologist, a neuro-oncologist, and spend a lot of my time in my lab working on research related to brain tumors, and also started a company developing mobile apps for stroke detection. So I'm going to try to talk about all those things today to give you a sense for what my regular schedule is like and how I spend my time. So a few disclosures relevant to actually my involvement in the stroke company, which I'll talk about at the end. So just as a background regarding my training, because I think it's helpful to see people's trajectories and how they came about going into the career path that they decided. So I did my undergraduate just downtown at NYU, where I was a major in neuroscience and received a Bachelor of Science. And then I went on to go back to Philadelphia, where I'm from, and received my MD, PhD degrees from Temple University, and I finished that in 2013. So then I popped back to New York again, and I came to Weill Cornell as an intern in internal medicine for our first PGY 1 year, and then went on to New York Presbyterian Weill Cornell for my neurology residency. So that's where I still am today. And then I just popped across the street to Sloan Kettering, where I did my neuro-oncology fellowship. And during residency at Cornell, we spent a lot of time at Sloan Kettering because our neurology residents here at the hospital serve as the neurology residents at Sloan Kettering. So we got a lot of exposure, and that was also one of the main reasons I chose Cornell for residency, was because I had already known I wanted to go into neuro-oncology. So I was one of these rare early differentiators where I knew I wanted to pursue a career in neuro-oncology pretty early on. And because my graduate work was in the field of brain tumor biology, I knew that my research and career interests matched pretty well as well. So in my graduate school, I worked under the chair of neuroscience at Temple, and I worked on metabolism. So I looked at cellular and viral oncogenes and how they relate to oxygen and glucose metabolism in a couple of different malignant brain tumors. And then I went on to work with Lou Canley, who at the time was the director of our cancer center here at Weill Cornell, continuing my work on glucose metabolism and other metabolic phenotypes in gliomas. And I'll talk about that work a little later in the presentation. So currently I have several different professional responsibilities here at Cornell. I serve as a neuro-oncologist at our hospital, where I conduct outpatient neurology clinics, and I also serve as a consultant on the inpatient side in the hospital. I serve as the course director for our preclinical curriculum in neuroscience. So all of the medical students, when they undergo their neuroscience neurology curriculum, I lead that course. And so I work on the planning, executing the curriculum, teaching, and then we also have worked last couple of years on implementing a curriculum that educates students on social determinants of health, which of course is relevant in all of our populations and increasingly more so in medical student education. And I also serve nationally on the board of directors of the leading organization dedicated to physician scientist advocacy, which is APSA. And I also serve as the chair of the resident fellow engineer faculty committee. So in that committee, we actually try to work with trainees to have them have a smoother transition from pre-doctoral training, so MD PhD programs or MD programs, through to residency, so that they can stay involved in research. So we do a lot of work trying to figure out where are the loopholes that cause people to leak out of that pipeline, and to hopefully keep them in academic research. So I thought I'd talk a little bit about neurology as a profession. Hopefully some of you may be interested in pursuing a career in neurology, so this might be relevant to you. So first, of course, you have to show interest in the brain. Many of you hopefully like the brain or think it's really cool. And that's how I felt when I was an undergrad, because I was a neuroscience major. And actually, neuroscience major for me was a little bit of an accident, because at the time at NYU, outside the counseling office, they had actual physical pamphlets going back a while. And every pamphlet had the name of a major on it. So English and chemistry and biology and neuroscience. So a friend of mine one day in our freshman year towards the spring, when our counselors like, you guys need to choose a major, we went up to the office and we just went down the line. They were all in alphabetical order. And we got to N and we saw a major in neuroscience and we thought, oh, that sounds pretty cool. And I think we both agreed that we thought biology was a little too general and we didn't really want to do biochemistry. We knew we wanted to do a science kind of major. And so that was it. That was how we became neuroscience majors. And that influenced, that sort of day in the counseling office influenced, my entire career, I would say. So sometimes you don't really know where you're going to end up, and it could just be an accidental experience that has a big impact on your life. So of course I was a neuroscience major, but of course any major can go into a field in medicine or neurology. And a lot of people would argue that those with expertise in humanities make physicians with better bedside manner. So I don't think the major is that critical in terms of influencing what you go into later, because most medical students, when they enter medical school, don't have any idea what career path they want to choose. And then of course, shadowing clinicians and researchers can build domain expertise, so it can make you familiar with the types of patients seen in the office, and of course influence your opinion of a day in the life, because if you're someone who doesn't like talking to patients but likes more hands-on work, then maybe going into surgery would be better. So spending time with a certain doctor in different settings, whether it's inpatient, outpatient, can really be helpful in allowing you to gain more insight to what career path you want to choose. And of course, that's the benefit of being a medical student. That's why we do clerkships in the hospital, all the different rotations, but you're of course welcome to have those experiences early on. And if any of you on this call are interested in shadowing or coming to my hospital to work, then just let me know and we can go through the volunteer application. So a neurologist manages a whole variety of conditions, including stroke and trauma, inflammatory disorders and seizures, problems with neuromuscular disease, dementia, and even simple things like headaches, right? Which probably the majority of you on this call have had a headache of some kind in the past, whether it's migraine or tension headache from all of the quizzes and exams you take. And then the same thing with sleep disorders. Probably the majority of you on this call have had problems sleeping at least one night in your life. So these can be managed by neurologists. So we really run the gamut from really severe acute issues like trauma and traumatic brain injury, all the way down to common complaints like headache and sleep. And in terms of subspecialties, so after you finish neurology residency, a lot of trainees end up going into fellowship, and this can be in a whole variety of disciplines. I mentioned like sleep, so sleep medicine. There are stroke fellowships. Of course, I did neuro-oncology fellowship, of which now there are a growing number of 34. There used to be less than 10 just a few years ago, so it's really rapidly expanding. And these can give you the opportunity, usually in 1 to 2 years, to become more equipped to handle particular diagnoses within these domains. And these are all board certifications. So they also lend more credibility to your practice of medicine. So my typical day, like today, for example, of course, giving lectures or talks, that's part of it. But in the lab, I organize and execute my experiments. So I lead a team of myself and a technician, sometimes some graduate students in our brain tumor experiments, lots of meetings. So this is, second meeting of the day. And sometimes it could be, 3, 4, 5 meetings. So I try to plan things accordingly. Just like 30 minutes ago, I was injecting my mice with drugs and imaging them with bioluminescence and MRI. Of course, you need to keep reading, which always is not enough, and writing, which is often too much, like grants and papers. I have a clinic on Wednesdays where I see a mix of brain tumor patients and patients with just neurological complaints who don't have any cancer, things like migraine, and even sleep problems. I do inpatient consults 1 week a month, general neurology attending 2 weeks per year. So that's where I oversee all the neurology patients admitted to the hospital, and then I supervise our resident clinic once a month. So that gives me the opportunity to teach residents and conduct more postgraduate medical education. And then from the educational side, of course, I'm in the leadership of the preclinical medical student curriculum in neurology. So I organize the class schedule, we teach lectures, small group sessions, write quiz questions, and answer disputes when they arise from the quizzes. So that is a 7-week session that runs from August to October. So we just finished that. So now we're just prepping for 2023. So I thought I'd review a case to get you all excited about neurology. This was one of my more interesting cases from residency, which I'll spoil it, doesn't have anything to do with cancer. But this is a 44-year-old woman that I ended up seeing in the ICU at Cornell. She had a history of depression, some undefined seizure disorder, and a prior gastric bypass. And she was presenting with a 2-month history of progressive withdrawal and fatigue. So she was just less engaged in life. And she was falling because she had weakness and confusion, and then became unresponsive. So she was basically in a coma pretty rapidly. And her physical exam was actually normal in terms of her vital signs, but her neurological exam was notable that she was stuporous, meaning she was unresponsive to most stimuli, although she did respond if you pinched her, and she would withdraw her arm and leg. And she had a diffuse hyperpigmented rash. She had MRIs. This was her MRI. And for those of you not familiar with MRI, this is what's called an axial flare sequence. And so this image on the right of this screen where my mouse is, that's the left and this is the right. So you're looking at a patient lying flat in front of you on a bed. So you're looking sort of up at them. This area here, this white, is supposed to be non-white. It's supposed to be more like this gray surrounding area. And this is the white matter of the brain that seems abnormal, diffusely throughout the brain. This is a diffusion weighted image, and this shows the failure of water transport across membranes, which often can be a result of ischemia, but it can be a result of a variety of other processes like tumors, brain abscesses when it's a localized lesion, and inflammation as well. When we did lab testing for her, she was actually pretty anemic. So she had a low hemoglobin and she had a low iron. She was also nutritionally deprived. Her albumin, which is a protein in the blood, was low. And her liver enzymes indicating liver dysfunction were elevated. Ammonia was slightly elevated, and she had a very the layer that surrounds neurons, and that was leaking into the spinal fluid, indicating damage to her nerve fibers in her spinal fluid. That's myelin basic protein. So I thought I would make this a bit interactive. So what do you think the culprit is, being undergraduates, probably with very little experience in interpreting cases, imaging, or labs? And I thought I would ask your perspective. So maybe what you could do is enter your thoughts in the chat. And I'll be curious to see what you say. Let me see if I can see the chat. Sort of disappeared. Oh, there we go. I can see it now. I'll pull it up. Anyone? You could just put a letter. A, B, C, D, and E. Okay, good. We have a B. We have 2 for B. Okay, good. Anyone else? Remember, her vital signs were normal. No fever. Okay, stuck between B and E. Good. Okay, so now we're sort of 2 Bs, a B and E, and an E. I think we're on the right track. Anyone else? All right, we have an E. We have another E. Okay, good. All right. Okay, very good. So we have a handful of responses. So few B's and possibly more E's. So the question is, okay, people who think of the toxic exposure, what would the culprit be? Does anyone want to venture a guess if you're willing to unmute and be brave and go out on a limb?
Would it be like a carcinogen or something like asbestos?
Yeah, it's a very good thought. So something like common in the environment. Yeah, good, very good thought. I'll say it's not those, but you're thinking on the right track. Any other ventures at a guess? All right. Well, what I'll say is that we did a diagnostic test, and the diagnostic test was a molecule called para-dichlorobenzene, or PDCB. So for those of you who've already finished organic chemistry, you probably know that benzene, right, is a aromatic ring, and in this case, it has a chlorine at the opposite positions, right? So if you remember para versus ortho, para is the opposite ends of the six-membered ring, so it just has two chlorines. That's what para-dichlorobenzene is. And it has a metabolite that you can measure in the urine, which is dichlorophenol. So phenol has the hydroxyl group on it with two chlorides. And the levels of both of those were elevated. Now, the question is, why did we perform that test? So this was a Saturday. I was in the neuro ICU. A patient was there, and she had come from Staten Island Hospital, where she was there for a few weeks with an unknown diagnosis, and then came to our ICU because they couldn't figure out her case, and came to us, and we also couldn't figure out our case. We did a lot of tests, we repeated things, and it was a Saturday, and I was there, and the patient's mother was in her room, and I went into the room early in the morning, and I said, we really don't know what's going on. Is there anything that we could be missing? Because we can't figure out why your daughter is really in a coma right now. We have no idea. And the imaging showed what I showed you, but it's non-specific. It doesn't say that's a diagnosis. And definitely no treatment based on that. And she said to me, well, her husband, who I don't like, this is the mother speaking, has been putting mothballs in her pillowcase. And I said, like, that's strange. Why would they be putting mothballs in the pillowcase? And she said, well, he thinks they're like good for her. And so she's been sleeping with these mothballs in her pillowcase for months. And the husband was somewhat abusive of her as well, and was kind of restricting her seeing different people. And I think that's why the mother didn't like her. And the wife was trying to file a restraining order against him. And so what happened was that mothballs either have two chemicals in them. One is naphthalene. This is sort of, if you ever use mothballs, there are mothballs that have naphthalene in them, and there are mothballs that have para-dichlorobenzene. And both molecules keep the moths away. But both molecules are also very fat soluble. So if you know anything about chemistry, the benzene ring is quite fat soluble and can accumulate in fat. So that could be in the abdominal fat, and it could be fat within the brain, which is myelin, right, which is a fatty tissue. And people who have prolonged exposure to these, and this has been well documented, can have what's called a leukoencephalopathy, so a white matter damage within the brain. And that white matter damage in the brain can be very chronic. And so after talking to the mother, we tested her, and of course those labs take a while to come back because it's not routinely done. We have to send those out to the Department of Health. And when they came back positive, we realized that that is probably the culprit. So this PDCB is a lipophilic aromatic hydrocarbon that accumulates in fat here in the myelin, and it induces oxidative stress because it reduces glutathione, and it increases superoxide, and it reduces superoxide dismutase. So it reduces the body's ability to get rid of oxidative molecules. And it also can cause abnormalities in calcium and acetylcholine. That's what can cause people to be weak. And also it exhibits this leaching effect because it accumulates in fat, and over time will continue to leach out of the fat. It's almost like the fat stores it and gradually sheds the molecule. So even if the exposure ends, and this is the case with many aromatic molecules, so people who sniff glue, or that was happening several years ago down south, that same effect can happen. It's called a coasting effect. So the molecule is out of the blood, and it can stay elevated in the blood because it leaches out the fat. And so that was the case with her as well. Even when the exposure ended, she was still being exposed to the molecule because the fat stored it. So So that was an interesting case. And interestingly, she was very anemic. And it's also been shown that mothballs, for some reason, are very appealing to those with iron deficiency anemia, which can cause a disease called pica. So pica, if you've ever heard of people who are iron deficient, like eating dirt, and actually, if any of you have watched the mini series on Hulu called The Great, which is about Catherine the Great, which is an excellent mini series if you ever have a chance to watch it, kind of like comical view of the Russian monarchy at the time. The lead, Catherine, in that miniseries has pica, and because she's pregnant, so she's bleeding during the pregnancy, and she keeps eating dirt, and that's what pica is. And the dirt is thought to be appealing because it's thought to contain high amounts of iron. So people unwittingly look for sources of iron. The mothball thing is unclear because mothballs don't have iron. But for some reason, people with pica have been known to consume mothballs or even toilet like discs they put in toilets, same thing. So we think that she was iron deficient because of her after gastric bypass, and then also because she had access to the mothballs, whether or not it was voluntary or whether her husband was actually putting them in her pillowcase, as the mother suggested. And eventually she was discharged to a nursing facility and then ended up dying about a month later from complications of her illness. So I thought that was an interesting case to review, and goes over, I think, a lot of interesting pearls about bedside medicine and also about neurotoxicology, which I think is fascinating. So I thought I'd switch gears and talk a little bit about what I do in lab to go over some of the research. So the broad goals of what I work on are to uncover targetable susceptibilities in glioma to metabolism. We try to use synergistic pharmacological regimens to examine glioma escape mechanisms, so how brain tumors can escape from resistance from chemotherapy or radiation. And we also use clinical data to strengthen our basic science findings and work in a multidisciplinary team. So we work across the spectrum from the basic and translational sides in neuro-oncology. So just an example of that is we have collaborations where we analyze clinical trial data with colleagues in Boston. Where we have a study actually out at Cold Spring in here where we're looking at the role of sleep in cancer immunity and metabolism. So I talked about sleep earlier, but sleep is also severely disrupted in patients with cancer, and especially in those who lose weight and exhibit cancer cachexia. And we have collaborations down in Philadelphia looking at targeted therapy in glioma. So as a physician scientist, this is often ways of being successful, is having collaborators with different institutions where they have different repositories of data and different expertise in various domains. So an example of the data about the clinical trial reevaluation is that our lab several years ago showed that suppression of insulin feedback can enhance efficacy of inhibitors that block a growth pathway called PI3 kinase, which you might remember from biology. And we work a lot with the ketogenic diet, and we found recently in work that we're submitting that if you add anti-hyperglycemic drugs like metformin, so these are drugs that lower blood sugar, to molecules that inhibit this PI3 kinase pathway, like this drug 0084, we can significantly improve survival. So these are just simple remedies that we can help improve efficacy of some of the agents that we use in cancer-directed treatment. And when we reevaluated patient data from this trial that used an inhibitor, we found that those patients who had very high glucose levels actually did much worse. So their survival was lower, as indicated by this upper p-value. And that's an indicator that there are often obvious mechanisms of resistance to disease that are not often taken into account. And so looking at those through these retrospective collaborations can be very helpful. So from a bedside perspective, one question that the patients of mine often ask in clinic, because the treatments that we offer for brain tumors are not very effective, is what else can I do for their cancer? Or what else can I do for their brain tumors? In the case of my patients, they're really asking what else can they take? So is it medicine, supplements, or what else can they eat? Is there a particular diet? There's a lot been said recently about the ketogenic diet in brain tumors and whether that can be helpful. And ultimately, the goal of that is for patients to help to live longer. But one aspect of treatment that we don't often think about is how patients are actually feeling during treatment. So we don't just want them to live longer, but we want them to have a higher quality of life and feel better. And that is a lot of the work that we're trying to do with diet and supplemental therapy to improve their well-being during treatment, not just give them treatments that can be toxic and hurt them for the long run, but hopefully improve their quality of life. And so with that being said, we work a lot on antioxidant biology. So here on the left and through the rest of the picture are foods that are rich in antioxidants like blueberries and cacao and red wine, olive oil, fatty fish, and cruciferous vegetables. So maybe at least one of these items will be on your palate this weekend. So these are all rich in antioxidants. So you can maybe feel better about having the red wine or the cocoa, especially as the winter season of hot chocolate comes to us. And there's been a lot that's been said about antioxidants in Alzheimer's disease and neurodegenerative disorders. So my colleague Richard Isaacson published the Alzheimer's Prevention and Treatment Diet, which goes over certain foods that are rich in antioxidants and that can help prevent the oxidative stress that occurs in this disease. So many of you may know about pathways regulating nutrient uptake from basic biology. But glucose is taken in by glucose transporters in the cell and leads to downstream metabolism of nucleotides, intermediates for the TCA or Krebs cycle that can lead to fatty acids and synthesis, and also proteins. So that's sort of the building blocks of cell that come from glucose alone. And then in the antioxidant side, several different amino acids and metabolites lead to the formation of oxidant and antioxidant molecules, as well as are regulated by various receptor tyrosine kinases. So these are proteins that help regulate oncogenes like PI3 kinase and also the mTOR pathway, and can be modified by issues in cancer. So for example, high PI3 kinase activity or abnormalities or amplifications of genes that regulate serine biosynthesis, amino acid deficiency, et cetera. And so cancer leverages these metabolic pathways to try to grow and rewires metabolism. And then from the antioxidant side, these same molecules can feed into pathways that regulate the redox state. So those are molecules like NADPH that comes from pentose phosphate pathway, and also from formate metabolism through folate. So one issue with antioxidants in cancer is that we know that antioxidants can counteract the damage that's caused by some of the therapies that we use, like radiation and chemotherapy, which are meant to damage DNA, as you might know. So antioxidants could make cancer worse as a result, and maybe it could be risky during chemotherapy. So the question is whether we should still give antioxidants. If someone's taking like a vitamin C or vitamin E during chemo, should they still do that, or should they change to different dietary supplements? Because possibly the supplements really don't fight cancer. They might be good for other diseases, but cancer is a little more controversial. And that's because the oncogenes in cancer can regulate the generation of ROS through hypoxia and metabolic stress, whereas antioxidants can eliminate that. And so the idea is that cancer likes to balance the production and elimination of ROS to be able to grow. If there's too much ROS, then which is reactive oxygen species, then the cancer will stop growing. But also you need a little bit of ROS in order to turn on some of these genes that are abnormal in cancer to make them grow. So it needs to be balanced. So what we did in our research is try to focus on one of the amino acids, which is called cysteine. So cysteine is an amino acid that leads to the production of glutathione, which is the main antioxidant molecule in the cell. And that's through the combination of cysteine, glutamate, and glycine. And cysteine can regulate ROS. It can regulate hydrogen sulfide, which is a gasotransmitter that regulates growth, as well as glutamate exchange that makes cells dependent on glucose to grow. And so what we did was we used a prodrug for cysteine, which is called N-acetylcysteine. And that's used in a number of human illnesses, including Tylenol overdose, asthma, and it's thought that it can be neuroprotective as well. So just a little bit about glioblastoma, which is what I work on. It's an incurable brain tumor with very little progress in even more than 15 years, even more than 20 years nowadays. There's about 25,000 new cases of brain tumors in general, and about 13,000 new cases of glioblastoma. And the general treatment is radiation combined with chemotherapy. with a prognosis right now of about 16 to 20 months with standard of care. And that hasn't really changed in about 20 years. So there's a lot that's been said about new therapies like polio, immunotherapy, targeted therapy, CAR T cells, and even a ketogenic diet. So I'm going to talk a little bit about our work on targeted therapy, looking at some interesting susceptibilities. So what we did was we treated our cells with L-cysteine. So based on what I was mentioning about this potential use of cysteine in these cells to make glutathione, we decided, well, what happened if we give our cells L-cysteine? And to our surprise, we found that these cells actually didn't grow very well. So this is a growth curve where at 24 hours, you can see the amount of growth on the y-axis really plummets when we give these cells high levels of cysteine. And when we combine that with methionine, which methionine can be converted to cysteine, we see the same effect, and methionine alone doesn't do very much. N-acetylcysteine kind of mimics this trend in L-cysteine, so it reduces growth of cells. And that's pretty counterintuitive because in cancer, it's thought that cysteine and N-acetylcysteine is kind of is protective against cancer growing. And so this was very different than prior results in other cancers. And thanks for the comment about the CAR T cells. I could talk about that maybe in the Q&A. So what we did was we continued to go down this route of studying NAC usage by these cells, and we gradually removed glucose from our medium, because we know that when cells start dying, especially with cysteine, they might become more glucose dependent because of the need to create glutathione from glucose. And what we found is that if we deprive our cells of glucose, we actually made the cells grow much less at 24 hours. These are a type of cell called IDH mutated cells, and these are IDH wild type cells, which have different metabolic phenotypes, but both are similarly sensitive. And our next series of experiments was to look at the mitochondria, because downstream of metabolism would of course be mitochondrial metabolism. So the TCA or Krebs cycle takes place in the mitochondria. So we wanted to see what happens in terms of OCR, which is oxygen consumption rate. So that's the rate at which the cells are respiring. Again, if you remember from biology, I'll just give you a comment here that the TCA cycle, of course, you learn in undergrad and in the future in medical school probably numerous times, and it's one of those things that you'll learn and forget and learn and forget. Even I constantly learn and forget it, but I think if you work on it, you start to remember it. So the things that you care about, they end up sticking. So just keep that in mind with all the rote memorization that you'll be undergoing in undergrad. Some of those things will come back to either help you or haunt you. So what we found is that if we gave these cells N-acetylcysteine, we saw that the oxygen consumption rate went down. So the cells were not respiring as much. And that was true in all the cells that we profiled. And that was not the case with neurons. So if we plated normal cells that were growing in the brain that we obtained from mice, we didn't see any effect of this drug on metabolism. And one thing that I mentioned that's associated with mitochondrial metabolism in the redox state of the cells, of course, is NADPH, which is a molecule that helps to reduce glutathione. And when we look at the ratio of NADPH to NADP, so this is the reduced to oxidized forms, which gives you an overall state of the redox sense of the cell, we could see a reduction in this level just at 5 minutes. So we add the drug, and 5 minutes later, we measure this and we can see a reduction. And the reduced glutathione levels go precipitously down. So we see that very, very quickly. So the cells are sort of running out of reducing potential. So they can't handle oxidative stress as well, because this is a measure of how well the cell can manage oxidative stress. And then when we look at transmission electron microscopy, this is a view of a cell. So up here is a nucleus. So this, you can see these electron dense areas here. These are histones and DNA that are condensed. And then you can see the organelles. This is exactly like what you see in the biology textbooks, right? You see the mitochondria with beautiful cristae. You can see the endoplasmic reticulum here. And I think not seen in this picture is the Golgi. But this is sort of the view of the cells that you learned about in textbooks. But when we give N-acetylcysteine, we see basically loss of these cristae. So you don't see these nice double membrane structures that are seen on the left really in this middle picture, and that's quantified on the right. So the NAC destroys the structure of the mitochondria just at 2 hours of treatment, so pretty quickly. And the mechanism that we identify, which I won't go into detail just for sake of time, is that we found that molecules like NAC induce this phenotype called reductive stress. And so in reductive stress, what happens is within the mitochondria, NADPH acts as electron donor. And if you remember, you need electrons to flow within the mitochondria to produce the proton motive force that drives protons to convert ADP to ATP. And if those electrons stop flowing, right, to create that force, then you don't get ATP generation. And in this case, what happens is at the end of this electron chain are electron acceptors. So these molecules basically shuttle these electrons and then start the process over again. And if you consume the electron acceptors, so if you take them out of the framework, then what happens is oxygen is around and finds these electrons, and oxygen, when it finds these electrons, can produce toxic molecules like hydrogen peroxide, which of course is the chemical in bleach. So essentially what we think is happening is that these drugs, and I won't go through the further data we have, is causing this process to occur, and that glioma exhibits a severe deficiency in these pathways on the right. So the glutathione reductase pathway, or GR, and the thyroidoxin, or TRX pathway here, and causes these cells to be very susceptible to this kind of stress. So we're testing this now in preclinical models where we give mice drugs that induce cysteine, or that give cysteine directly to the mice. And then we do a series of experiments to look at how well the tumors are growing using bioluminescence or MRI scans or even PET scans to look at